بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second talk in the series of diagnostic radiology in English, which are referred to by the abbreviations DRE. And now we'll start the discussion of the cerebrovascular diseases. And the first talk has been discussing the normal anatomy of the brain, including the venous and arterial anatomy. Then we'll proceed now in the evaluation of the cerebrovascular diseases. And before we start, we have to emphasize some of the terminologies that we usually use while discussing this issue. And this is actually for the junior staff in order to set up some of the facts before starting or going deep into this subject. Whenever we are dealing with the CT scan without intravenous contrast injection, and we use these three terms. Number one, a hypodense lesion, which means that there is a lesion that is of lower density compared to the normal brain parenchyma. A hyperdense lesion is the lesion which is more dense than the usual or the normal brain parenchyma. An isodense lesion is usually of similar CT density to the normal brain tissue. Then you are not able to identify the lesion itself, but you will identify the effect of the lesion on the normal brain structures. As you see in this case, normally you will see the ventricles, the left one and the right one are standing on either side of the midline plane. But in this example, you can see that the right lateral ventricle is compressed and is contralaterally displaced to the left side across the midline. Then there should be a lesion here that has compressed the ventricle and displaced it to the opposite side. And because we don't see the lesion, we will say that this is an isodense lesion. Then why some of the lesions are hypodense, others are hyperdense, and some of the lesions are isodense? That's because what is known as the CT density or the CT attenuation value. And this means that certain tissues have a certain capacity for reflecting the X-ray beam. Then according to the density of the tissue, then you will see the lesion on the CT scan. Normally, the brain tissue measures in its density around 30 to 40 units. And these units are referred to by these letters HU, H for Hounsfield. And Hounsfield is the British physicist who has introduced this CT machine in the late 70s and early 80s. Then the normal brain tissue is around 30 to 40 Hounsfield units. Any structure or lesion that measures a density below 30, it will appear black or hypodense. And any structure or lesion which will measure above 40 Hounsfield units will appear hyperdense or brighter than the tissue of the normal brain. And these are the attenuation values which are well known for every radiologist. The CSF measures in attenuation from 0 to 15 Hounsfield units. Fat usually measures by minus from 100, minus 100 to minus 200. Air is more hypodense than fat and measures more minus readings starting from 300 and above. Then if you look here to this CT scan, and you can easily identify that air is black or hypodense. The fat in the orbit is also black or hypodense. Then the CSF in the cisterna magna, for example, or the prepontine cistern appear black or hypodense because of its attenuation value. Then other lesions that may have hypodense appearance, including the infarctions. Infarction means dead brain tissue, as we will discuss immediately, and this dead brain tissue will appear relatively hypodense compared to the normal brain parenchyma. Also, brain edema around the tumors, around abscesses, around any lesion will appear like this. And you see a space occupying lesion here surrounded by what we call finger-like vasogenic brain edema. And this edema appears hypodense, as you can see. Then many of intracranial cysts will appear of low density or hypodensity according to the cyst content. And this is an example of a hydatid cyst in the cerebral parenchyma, showing hypodensity almost similar to that of the CSF, because you know that the contents of the hydatid cyst are almost similar to water. Then what are the lesions or the structures that may show hyperdensity on the non-enhanced CT scans? Number one is the recent blood. The fresh hemorrhage or the recent hematoma will appear hyperdense compared to the normal brain parenchyma, because recent blood measures about from 60 to 90 Hounsfield units. Then calcium. Calcification, as you can see in this example, calcification in the basal ganglia, in the head of the caudate and dentiform nuclei. Also, calcification in the choroid plexus, calcification in the pineal body will appear hyperdense compared to the normal brain parenchyma, because calcium measures above 200 Hounsfield units. Then, if there is an intracranial lesion and this lesion is sizable enough to produce what's known as mass effect, and this mass effect will be expressed in one of three or both the three items. Number one is the effacement of the cortical sulci, which means that on the same side of the lesion you cannot see the normal cortical sulci on the surface of the brain. Look at the normal hemisphere and you can see cortical sulci on the surface of the brain. And here, because of the lesion, which is an isodense lesion, you cannot see the cortical sulci. Number two in the mass effect is the compression of the ventricle. And this is a minor effect and this is a moderate effect, where the ventricle is compressed but it will stand on the same side, on its anatomic side. Then the third step is the shift of the midline structures. The ventricle is compressed and also shifted to the opposite side. Then you can see here, this is the hematoma in the left cerebral hemisphere and is compressing the left lateral ventricle, which is more or less still on the same side or does not cross the midline. But here there is an isodense lesion that has compressed the ventricle and displaced it across the midline to the opposite side. Then the brain edema are one of three types: the cytotoxic edema, the vasogenic edema, which is a finger-like hypodensity around some of the lesions. The cytotoxic edema is a rim of hypodensity around some of the lesions. And periventricular edema is the edema around the obstructed ventricles due to obstructive hydrocephalus. The CSF will go back across the wall of the ventricle, what we call retrograde transependymal CSF permeation. And this third type of edema, which is known as periventricular edema, is seen in cases of obstruction to the CSF flow with retrograde backflow of the CSF around the ventricles, producing these hypodensities. And the vasogenic edema is also further subdivided into grades. The grade 1, which means that there is a finger-like hypodensity measuring less than 2 cm around the lesion. The grade 2 perifocal edema is a hypodensity measuring more than 2 cm but less than the cerebral half more than 2 centimeter, but less than half of the cerebral hemisphere where the lesion is seen. Then the grade 3 perifocal brain edema is an edema or a hypodensity which is more than half of the cerebral hemisphere where the lesion is existing. Then we have 3 grades. The grade 1, which is usually seen around less aggressive lesions, and the grade 3 is seen around the aggressive lesions in general. Then we'll discuss the diagnosis of intracranial hemorrhage and intracranial ischemic lesions. We'll start by the discussion of the intracranial hemorrhage. Look at this drawing where you can see these are the calvareal bones in black color, and this yellow color, this blue color represents the dura, and this red color represents the site of the arachnoid membrane, and here is the pia mater adherent to the surface of the cerebral hemisphere. Then if hemorrhage is going to occur in one of these places, hemorrhage can occur in this space between the calvareal bones and the dura, and then the name is an epidural or extradural hemorrhage. And hemorrhage may occur underneath the dura, and this is known as the subdural hemorrhage, or underneath the arachnoid membrane, and at that time hemorrhage will go inside the cortical sulci, and this is known as the subarachnoid hemorrhage. Also, hemorrhage can occur inside the cerebral hemisphere itself or inside the ventricle, and is known as intraventricular hemorrhage. Then we should know that the acute hemorrhage will appear hyperdense on the CT scan, and by time this hyperdensity will decrease until it is hypodense. Then acute hematoma is hyperdense compared to the brain parenchyma. Chronic hematoma will be hypodense compared to the brain parenchyma, and the subacute hemorrhage will appear of similar density to the normal brain parenchyma. Then look at here, this is the blood which is hyperdense compared to the normal brain parenchyma, and this is acute hematoma. And here is the blood which is black or hypodense compared to the normal brain parenchyma, and this is the chronic hematoma. And this hematoma is approaching the same density of the brain tissue, and this is a subacute hematoma. Then acute blood will appear bright or hyperdense. Chronic blood will appear black or hypodense, and the subacute blood will appear gray or isodense to the normal brain parenchyma. Then we'll start first by the easiest of them, which is the subarachnoid hemorrhage. And you know, the normal CT brain will show the ventricles on either side of the midline, and the cortical sulci on the surface of the cerebral hemisphere, and these cortical sulci are usually filled by CSF, and CSF is hypodense, as you all know. And if you have a CT scan, and you can see that the CSF in the cortical sulci is no more hypodense, but it is hyperdense, meaning that there is fresh blood or acute blood running or smearing in the CSF spaces, and then at that time you should diagnose the possibility of the subarachnoid hemorrhage. But if you see hematoma which is adherent to the calvareal bones, the inner table of the calvarium, and this hematoma is running parallel to the calvareal bones, then if you see hemorrhage like this and you think that this hemorrhage is not inside the brain parenchyma, it should be outside the brain parenchyma. And outside the brain parenchyma, we have 3 spaces: the epidural space, the subdural space, and the subarachnoid space. The subarachnoid space, we finished with it. As I have said, that the subarachnoid hemorrhage will go inside the cortical sulci and fissures. Then this hematoma will represent either an epidural hemorrhage or a subdural hemorrhage. How can you discriminate between both? And in a simple way, you should look to the inner border of the hematoma. If the inner border of the hematoma is convex, then you are dealing with epidural hematoma. If the inner border of the hematoma is concave, like this one, then you are dealing with a subdural hematoma. And the epidural hematoma has a convex inner margin, because you know that the dura represents the periosteum of the calvarium, and this is a very tight space, and the extension of the hematoma up and down is very limited, but the enlargement of the hematoma from its middle can occur easily. Then you see epidural blood with convex inner border, but the subdural space is wide, and the hematoma can have the contour of the surface of the cerebral hemisphere. Number two, the hematoma, the epidural hematoma, can cross the midline. If you see blood here in between the calvarium and the dura, and this blood, if it is near to the midline, it can cross to the opposite side. But the subdural hematoma cannot cross the midline because it will extend into the fissure, into the interhemispheric fissure, and it is bordered by the dura of the falx, which prevents the hematoma from crossing the midline. Then epidural hematoma is almost always acute because of the symptoms. The epidural hematoma initiates acute symptoms, and the patient go quickly for a CT scan, and he discovers the hematoma, and the hematoma is evacuated. But the subdural space is wide, and the hematoma can exist for some time in the subdural space. So you can see the subdural hematoma in the acute phase, or in the subacute phase, or in the chronic phase. And this is a good drawing showing the difference between epidural hematoma and the subdural hematoma concerning the point of crossing the midline. This is an epidural blood, and the epidural blood can easily extend to the opposite side across the midline, but the subdural blood will not be able to cross the midline because it will extend into the interhemispheric fissure. And this is an example of an epidural hematoma occurring near to the midline, and you can see the crossing of the hematoma across the midline. The hematoma is adherent to the, or intimately related to, the calvarial bones, and the inner border of the hematoma is convex, diagnostic of an epidural blood. Then the epidural blood is, or epidural hematoma, should have a convex inner margin, is almost always acute, and it has a good relationship to the traumatic insult. But the subdural hematoma occurs in a wide space. It can be acute, like this one, or subacute, like this one, or chronic hematoma, like this one. Then the subdural hematoma has a concave inner margin. It can be acute, subacute, or chronic. You may be seen in elderly patients with history of minor trauma, and it can also occur in the interhemispheric fissure. Then if you look to this hematoma, and you see a large hematoma extending parallel to the calvarial bones, intimately related to the inner skull table, and this is a good example for the subdural hematoma. And whenever approaching the midline, the subdural hematoma cannot cross the midline, but instead it will extend into the interhemispheric fissure. As you can see, this very small extension into the interhemispheric fissure. The hematoma being large, it produces severe mass effect in the form of effacement of the cortical sulci, compression of the ventricle, and contralateral shift of the midline structures. This is another example of acute subdural hematoma on the right side, and it has a concave inner margin, and you can easily identify that this hematoma is extending into the interhemispheric fissure posteriorly. The hematoma cannot cross to the opposite side. The hematoma, being large, produce a severe mass effect in the form of effacement of the cortical sulci, severe compression of the right lateral ventricle, and contralateral shift of the midline structures. Then the subdural hematoma can only be seen in the interhemispheric fissure on the midline. And you know there is no epidural space in the midline because both dural surfaces will come into contact with each other. Then the subdural hematoma can occur on the convexity of the cerebral hemisphere and can also occur in the interhemispheric fissure or in the falx or also across the tentorium. Then you should remember this hematoma has a convex inner margin, but this is not an epidural hematoma because there is no epidural space in the midline. So if you see blood or pus or any collection in the midline across the falx cerebri, then you should think that this is a subdural collection because there is no epidural space in this area. Then we came to the intracerebral hematoma, and intracerebral hematoma may be post-traumatic, and at that time we call this a cerebral contusion. In this area, you see the fracture, which is the breast, and you see hemorrhagic foci surrounded by edema. This is known as brain contusion. And intracerebral hematoma can occur secondary to hypertension or diabetes, and this is non-traumatic intracerebral hematoma. And you can see the hematoma has no relation to the calvarium, and it does not extend along the calvarium, similar to the previously mentioned two types of extraaxial blood. In the intracerebral hematoma being adjacent to the ventricle or near to the ventricle, it has the chance to go inside the ventricle. Then, if you see a hematoma like this, and you should specify its side, this is the left and the posterior parietal hematoma, has extended inside the ventricle on the left side as well as on the right side. And you know that the blood is heavy than the CSF, and because of the patient is lying on his back, then you expect that the blood will accumulate in the occipital horns of the ventricles. Then some hematomas can extend inside the ventricle and others cannot extend inside the ventricle. The radiologist's role here is just to comment on the hematoma and if it has extended inside the ventricle or not. What are the factors controlling the extension of the hematoma inside the ventricle? No known factor can control this. The extension of the hematoma is not a subject for the size of the hematoma or the age of the patient or the cause of the hemorrhage. Some of the hematomas can extend inside the ventricle, and we mentioned this in the report, and others do not extend inside the ventricle, and we also mentioned that in the report. Then this is a good example of an epidural hematoma where you can see in the blood which is intimately related to the calvarium with convex inner margin and the significant mass effect on the ventricle. Then what is the fate of this epidural hematoma? This epidural hematoma will be discovered usually in the acute phase, and it is rapidly evacuated because of the severe symptoms resulting from this blood or this huge blood in this very tight space. Then an epidural hematoma, if it is small, it can be left to resolve, and at that time you can see the hematoma in the acute phase, and after some time you will see it in the subacute phase, and later on you will see it in the chronic phase. And you can see here, this is a male patient, 11 years old, with recent calvarial fractures and subgaleal hemorrhage. But if you look to this epidural hematoma, and you can see that the hematoma is no more bright, and in spite of being acute, it is not hyperdense. And this can be seen in anemic patients with very low hemoglobin level, like let's say 4 or 5 milligram. Then if you see a hematoma like this, then you can expect that this is a relatively subacute or chronic hematoma, but considering the recent history of trauma, the presence of fractures, and the presence of subgaleal blood, and this is an acute hemorrhage, but the acute hematoma here is not that bright because the patient is anemic. Then The subdural hematoma can be seen hyperdense in the acute phase, isodense in the subacute phase, and hypodense in the chronic phase. Because the subdural space is wide and the hematoma can exist for some time in this without producing significant symptoms, then you may have the chance to see the hematoma in all phases. Then we used to teach our junior staff about the isodense lesions, the differential diagnosis of isodense lesion producing mass effect and you cannot see the lesion. Then if you look here, this is a subdural subacute hematoma producing a mass effect, compressing the ventricle and displacing it to the opposite side. In this example, you cannot see the ventricle, which is compressed, and you cannot see also the cause of ventricular compression. Then whenever you are confronted by an isodense lesion, which is producing a mass effect on the CT scan, then remember that you are most likely in the differential diagnosis of one of two, either the subacute subdural hematoma or an infiltrating glioma. Before the era of MRI, we used to inject contrast media and to look carefully at the gray-white matter interface. If you can see the gray-white matter interface, then the lesion should be outside the brain parenchyma and you can diagnose easily the subacute subdural hematoma. But if you cannot see the gray-white matter interface, it is infiltrated by the tumor, and then you may assume the possibility of a glioma. But after MRI, it's easy to separate both lesions. This is hemorrhage outside the brain, and this is infiltrating type of the glioma, which we'll mention in the lecture of the brain tumors. Then what happens if you see a subdural blood which has two components, a chronic component and an acute component, what we call the sedimentation level? And at that time, we should diagnose this hematoma as the subacute subdural hematoma. Then one of the appearances of subacute subdural hematoma is an isodense collection to the brain parenchyma producing mass effect. And the second appearance is a hematoma with a sedimentation level. And this is a good example of a subacute subdural hematoma on the right side with the characteristic sedimentation level and a considerable mass effect on the ventricle with shift of the midline structures to the opposite side. Also, you can easily identify the extension of the hematoma into the anterior as well as the posterior parts of the interhemispheric fissure or within the falx. Then if you see a hematoma which is mostly hypodense, meaning that it's chronic, then you can identify 2 or 3 spots of hyperdense acute blood inside the hematoma. Some of the books would say that this is a subacute subdural hematoma because it has the two main components of the blood, the chronic one and the acute one. But many of my colleagues prefer to diagnose this as a chronic hematoma with an attack of rebleeding, and you can choose whatever you like. This is a chronic subdural hematoma showing hypodense texture compared to the brain parenchyma and is outside the brain parenchyma, as you can see by the displacement of the gray-white matter interface and the compression of the ventricle. Frequently, the subdural hematoma occurs bilaterally. Then you can see here bilateral chronic subdural hematomas. Usually, it may be larger on some side, on one side compared to the opposite side. And frequently, these types of hematomas are presented in the exam because many of the candidates will look at the sizable hematoma and forget to look at the smaller one on the opposite side. Then if you see a hematoma inside the brain parenchyma, this hemorrhage may be one of two, either the hypertensive bleeding or the post-traumatic bleeding. Then a third source of hemorrhage inside the brain parenchyma is the tumor that has been the site of acute hemorrhage. And you know that many of the tumors, especially the aggressive ones, can bleed, and the most common lesions which show internal hemorrhage are the metastatic deposits and the aggressive gliomas, especially the GBM or the glioblastoma multiforme. But you should remember also some meningiomas may contain hemorrhage, adenomas, especially the pituitary, may contain hemorrhage, and some of the neuromas as well. Then how can you discriminate between a hemorrhagic tumor and a hypertensive bleeding? It is usually by the surrounding edema, and the surrounding edema around the hypertensive bleeding is in the form of a rim of hypodensity, as you can see here, but in the edema around the hemorrhagic tumor will appear as a finger-like edema, which is usually seen around the tumors and abscesses. Then, if you are asked what is the source of intraventricular bleeding? Intraventricular bleeding, the commonest source is an intracerebral hematoma that has extended inside the ventricle because of its intimate relation to the ventricular wall. But another source of intraventricular bleeding is the backflow of subarachnoid blood into the ventricular system. Then here you can see the subarachnoid hemorrhage in the cortical sulci and sylvian fissure, and you can also identify hemorrhage within the third ventricle. These are the main two causes for intraventricular bleeding: intracerebral hematoma ruptured inside the ventricle, and a subarachnoid hemorrhage with backflow into the ventricular system. One of the common causes of subarachnoid hemorrhage is the rupture of an intracranial aneurysm, besides, of course, the traumatic insults as well. Then you can identify the site of the bleeding aneurysm. I will discuss this in full details in the lecture of intracranial vascular malformations. By you see the site of the ruptured aneurysm by an area of hemorrhage surrounding actually the site, and this is the commonest site for an anterior communicating artery aneurysm. Then here you can see the hematoma, and also you can see hemorrhage inside the ventricles. Then this is the subarachnoid hemorrhage secondary to rupture of an anterior communicating artery aneurysm, and you see the hematoma, which is exactly at the anatomic site of the anterior communicating artery, and then you see hemorrhage in the cortical sulci and the interhemispheric fissure, as well as the sylvian fissure, representing the subarachnoid hemorrhage, and also hemorrhage inside the third ventricle and both lateral ventricles. And this is a rare cause of an intraventricular bleeding, which is an arteriovenous malformation in the wall of the ventricle that has bled inside the ventricle itself. And the most two common causes of intraventricular bleeding are the intracerebral hematoma rupturing inside the ventricle and the subarachnoid hemorrhage. But this relatively uncommon cause, which is an arteriovenous malformation, as seen in this DSA selective angiogram, that has ruptured inside the ventricle, as you can see. Then you may remember this as the third cause of intraventricular bleeding. The first one is the presence of an intracerebral hematoma. The second one is the secondary to the subarachnoid hemorrhage, and the third one is due to rupture of a small arteriovenous malformation in the wall of the ventricle, producing intraventricular hemorrhage. Then we came to the discussion of intracranial hemorrhage from the point of MRI. And you know that there are 5 places for intracranial hemorrhage, as we have said: the epidural blood, subdural blood, subarachnoid hemorrhage, intracerebral hemorrhage, and intraventricular bleeding. Then you should remember that acute hematoma on MRI has another name, which is according to the hemoglobin present in this hematoma. And then the acute hematoma contains what's known as deoxyhemoglobin. The subacute hematoma contains methemoglobin, and the chronic hematoma contains hemosiderin. And the appearance of hematoma in MRI is quite different from its appearance on the CT scan. But please remember that whenever the hematoma is formed, and you have seen the hematoma on MRI, and the hematoma will change rapidly from the acute phase to the subacute phase to the chronic phase. And the change is usually from the periphery towards the center. From the periphery towards the center. Then, each hematoma is surrounded by some degree of perifocal brain edema, and the edema is usually little whenever you are going to the old stages of the hematoma itself. Let us look at the MRI appearance of intracerebral hemorrhage. We have the T1 and the T2 weighted images, and the hemorrhage in the acute phase, or what is known as the oxyhemoglobin, will appear gray in the T1 and black in the T2 weighted images. The subacute blood or the methemoglobin will appear bright in the T1 and bright in the T2. The chronic blood or the hemosiderin will appear black in the T1 and also black in the T2. Then you may consider that the acute blood is black in both T1 and T2. The chronic blood is black in both T1 and T2, and the subacute blood is bright in both T1 and T2. Then go to this appearance. This is T1 and this is T2. Then if the hematoma is changing from acute to subacute to chronic from the periphery, then the central part of the hematoma will be the most recent one. Then the central part of the hemorrhage will be the acute hemorrhage, which will show a gray signal in the T1 and the dark signal in the T2. Then this acute blood will be surrounded by a zone of subacute blood, which will appear bright in the T1 and also bright in the T2 weighted image. And this subacute blood will be surrounded by a rim of chronic blood, which will appear black in the T1 and black in the T2. The hemosiderin is well demonstrated in the T2 rather than in the T1 weighted images. Then outside the rim of the hemosiderin, you will see hyperdensities representing the edema surrounding the hematoma, and the edema is of low signal in the T1 weighted image, so you cannot appreciate the edema in the T1, but you appreciate its mass effect. Here you can see the cortical sulci. Here you cannot see the cortical sulci. They are effaced, and the ventricle is also compressed. Then the acute intracerebral hematoma or the deoxyhemoglobin will appear gray or intermediate signal in the T1 and black signal in the T2. And in the T2, you will see a zone of high signal which represents the edema around the hematoma. And this is the acute blood, and this acute blood is easily identified on the CT scan. Hence the role that the CT scan, it should be the first line of investigation in acute neurological cases, in order that the CT is more sensitive and more better for detection of acute blood compared to the MRI. Then look at this example, and you see a hematoma here in the temporal lobe on the left side. This hematoma has a gray signal or intermediate signal in the T1 weighted image and the dark signal in the T2. And in the T2 you see a bright signal of edema surrounding the hematoma itself. Then the subacute blood will appear bright in the T1 and also bright in the T2. This is methemoglobin. And if you look carefully in the T2 in particular, you will see the rim of hemosiderin around the hemorrhage. And outside the rim of the hemosiderin, you will see the brightness of the surrounding perifocal brain edema. Then this is a classic example of a subacute subdural hematoma. And you see the subacute blood is bright in the T1 and also bright in the T2 weighted image. Remember the T1 is identified by the black appearance of the CSF, and the T2 is known by the bright appearance of the CSF. Then this is a subacute subdural hematoma. You see a high signal in the T1 weighted image with mass effect, compression of the ventricle, effacement of the sulci, and minimal midline shift to the opposite side. Then the subacute epidural hematoma. This is an epidural hematoma with convex inner margin. And this epidural hematoma is bright in the T1 and bright in the T2, indicative of methemoglobin, diagnostic of subacute blood. This hematoma has passed into the subacute phase because of its small size. If it is large, then the hematoma will be evacuated before reaching the subacute phase. And this is a subacute epidural hematoma in the frontal area. And you see the brightness of the blood in the T1 and the brightness of the blood in the T2 weighted images. Every one of you should know this fact that the blood, whenever it stops flowing inside the vessel, it will appear exactly like the hematoma, considering the stages, the acute and subacute and the chronic. Then venous or arterial occlusion or thrombosis will show in the acute phase gray signal in the T1, dark signal in the T2. In the subacute phase, it will appear bright in the T1 and bright in the T2. And this is the only phase where you can confidently diagnose venous thrombosis or arterial thrombosis from the MR images. But you can refer to MR angiography and MR venography to confirm the diagnosis. Then, if you look here, the superior sagittal sinus contains high signal blood, which means that you are dealing with a subacute thrombus in the superior sagittal sinus. And in the axial images, you see the sinus of bright signal, diagnostic of subacute thrombosis. Also, you can see the veins on the surface of the brain contains a subacute blood signal, high signal in the T1 representing subacute thrombus. Then, let us look at these diagrams. In the T1 weighted image, the hematoma, the acute hematoma will show gray signal or intermediate signal and dark signal in the T2. The subacute hematoma will appear bright in the T1 and T2 weighted images. But there is an intermediate phase here, which is known as the early subacute hemorrhage. The early subacute hemorrhage will appear bright in the T1, then will be black in the T2 weighted image. Then the oxyhemoglobin or acute blood will appear gray and black in the T2 weighted image. The methemoglobin, which in this phase will be inside the RBCs before rupturing, which is known as intracellular methemoglobin. Intracellular methemoglobin will appear bright in the T1 and dark in the T2, while the extracellular methemoglobin or the late subacute hematoma will appear bright in both images. Then look at this MRI, T1 and T2 weighted image. Look at this hematoma, which is bright in the T1 and dark in the T2, and this is subacute subdural subacute hematoma, intracellular methemoglobin. Then look at the smaller component here, which is gray in the T1 and the black in the T2, and this is acute blood, which is the oxyhemoglobin, gray in the T1 and the dark in the T2 weighted images. Let us look at this hematoma, which is composed of two parts in the T1, the bright one and the gray one. Both parts will appear dark in the T2 weighted images. This part is acute blood, gray in the T1, dark in the T2. This part is early subacute blood, bright in the T1 and dark in the T2. Then let us put a rule. Whenever you see blood which is bright in the T1, consider subacute hemorrhage. Consider subacute hemorrhage. If the hemorrhage is bright also in the T2, then this is the late subacute hematoma, which is extracellular methemoglobin. If the hematoma is bright in the T1 but still dark in the T2 weighted image, this is the early subacute blood, which is intracellular methemoglobin. And look at this hemorrhage. In the T1 weighted image is bright, and the T2 weighted image is dark, surrounded by a rim of edema. Then you know that this is early subacute hematoma, intracellular methemoglobin. We usually write this in the report, early subacute blood, and between brackets we mention that this is intracellular methemoglobin. Then the problem of the hyperacute blood and the long-standing, very old blood. Both these two types of bleeding will appear like fluid. Blood of fluid signal. The fluid will appear dark in the T1 and bright in the T2. And this is a special signal for the hematoma, which is hyperacute in the first 6 hours of the insult, and the very old, long-standing hematoma. So, if you are confronted by a case like this, and this is an important man that was subjected to the cerebrovascular insult, and because of his importance, he went immediately for MRI bypassing the CT scan. Then in MRI, you can see a lesion in the posterior parietal area or parieto-occipital region, which is of intermediate signal in the T1 and high signal in the T2, which may look like a neoplasm. Then having a look on a CT scan of this patient done after the MRI, and they can easily identify the acute or the hyperacute hematoma. Then we came to the problem of infarction or the ischemic strokes. And you should know some facts about infarctions. Infarction is a hypodense lesion, whether it is acute, subacute, or chronic. And you should remember that infarction is not a space-occupying lesion, meaning that infarction cannot produce a mass effect or induce a mass effect on the ventricles by itself. Infarction will produce this mass effect by virtue of the surrounding edema. Then infarction should have a vascular territory belonging to one of the major arteries, anterior cerebral, middle cerebral, or posterior cerebral. Infarction in most of the cases has a cortical distribution. It has a good surface on the good base on the surface of the brain, especially if it is large like this one. Then, being a hypodense lesion, how can you know the acute infarction from the subacute infarction from the chronic infarction? You remember that acute infarction cannot produce a mass effect by itself. The infarction produces mass effect on the ventricle like this one by virtue of the surrounding edema. The edema is black and the infarction is also black. So you cannot easily discriminate between the edema and the infarction. But whenever you see a CT scan like this and you can see an infarction like this one, and you see also associated mass effect and ventricular compression, then you should say that this is an acute infarction. And after some time, the infarction will liquefy, and there should be loss of volume of the infarcted area. Then the ventricle adjacent or on the same side of the infarction will dilate to compensate loss of volume. So if you see an infarction compressing the ventricle, this is acute. If you see an infarction dilating the ventricle, this is chronic infarction. And if you see an infarction which has no effect on the ventricle, and this is the subacute infarction. And the infarction is usually the result of arterial thrombosis or embolism, and the artery is occluded, and the occlusion will appear exactly like the hematoma, and the hemorrhage in the CT will appear hyperdense like this, and this is hyperdensity is present in the middle cerebral artery corresponding to this infarcted area, and this is what we call the hyperdense vessel sign. The hyperdense vessel sign means that the middle cerebral or any one of the major vessels is thrombosed, showing hyperdense course, indicating that the area supplied by this artery is infarcted. And sometimes you can see the hyperdense sign, but you cannot see the infarction itself because the brain tissue the dead brain tissue to appear in the CT scan may need some time. Then you call this hyperacute infarction. Then if you look here and you inject the patient with contrast media, and you expect that the middle cerebral artery, which is thrombosed, will not enhance or will not show contrast material inside. This is an infarction because of middle cerebral artery thrombosis. The opposite middle cerebral artery is well delineated with the contrast material. And if you see this very classic hyperdense vessel sign, which is the commonly seen in the middle cerebral artery, and you may not be able to appreciate the hypodensity of the infarction in this cerebral hemisphere, and this is known as hyperacute infarction or the hyperdense vessel sign, which means that you are dealing with a hyperacute infarction that after some time will appear in the CT image. Then in this MRI, and you can see an infarction here, which is any infarction in MRI will appear black in the T1 and bright in the T2. But in order to see the exact distribution of the infarcted area and to see whether there are other infarctions that cannot be seen in the T1 and T2 weighted images, you should have the diffusion weighted images. And we'll discuss this in details after that, but for the current time, you should know that the acute infarction will show restricted diffusion and the diffusion weighted MR images, meaning that whenever the CSF is black, the infarcted area will appear bright, and this means that restriction of the diffusion here in this particular area. And you can easily appreciate the well delineation of the infarcted area by the diffusion weighted images compared to the T1 and the T2 weighted image. Then you may use the facility of MR angiography and to have this MR angiogram for the intracranial circulation, and you can see the attenuated, markedly attenuated middle cerebral artery on the same side of the infarction. And this is also a good example of acute middle cerebral artery infarction by T1 weighted image. You see the low signal infarction compressing the ventricle, and the T2 weighted image you see high signal infarction, and in the diffusion weighted image you see the restricted diffusion in the infarcted area, and by MR angiogram you can see the absence of flow in the middle cerebral artery as well as its branches on the right side. Then chronic infarction is an area of the brain tissue which is dead and liquefied with the consequent loss of volume and the compensatory vasodilatation of the ipsilateral ventricle. After some time, the infarcted area contains the fluid and the ventricle also contains the fluid. Both fluids are only separated by the very thin ventricular wall. Then sometime the infarction and the ventricle comes into are continuous with each other, and if this happens we call this porencephaly or acquired porencephaly or porencephalic cyst. The porencephalic cyst means that there is an area of dead brain tissue that has been totally liquefied and now communicating with the ventricular lumen. Then I hope you remember the words I have said about the mesial temporal sclerosis when I was discussing the anatomy of the region of the hippocampus and its relation to the temporal lobe epilepsy. And I have said that mesial means medial, temporal means temporal, sclerosis means gliosis. And also I have said that this area is better evaluated in the coronal images, especially the T2 weighted images and the FLAIR as well. And the diagnosis is based on the change of the signal and the change of the volume of the hippocampus compared to the opposite side. Then if you see here, then this is the temporal horn of the right lateral ventricle, which is relatively dilated compared to the opposite one, and you see this increased signal in the region of the hippocampus in relation to the temporal horn. And in the coronal images, you can easily appreciate the marked loss of volume of the hippocampus on the right side compared to that on the left side, with abnormal increased T2 signal in the affected hippocampus. These findings are usually diagnostic of mesial temporal sclerosis, and they represent a good explanation for the complaint of the patient of seizures. Then this is the left-sided hippocampal sclerosis, and you can see the small volume of the hippocampus compared to the opposite side, and the relative increase in the signal compared also to the right side. Then the mesial temporal sclerosis may occur primarily because of ischemic changes in the region of the hippocampus, or secondary to other lesions, like this in this case with a patient with occipital lobe abscess that has been evacuated, and after that the patient developed epilepsy or seizures, and the MRI showed that there is some changes in the hippocampus on the left side, which are clearly identified in this FLAIR image. You see the abnormal signal in the hippocampus and the loss of volume compared to the opposite side. And subacute infarction is the infarction which does not affect the ventricle. There is no compression nor dilatation. And this stage of the infarction is in between the acute one and the subacute one, can be easily diagnosed by identifying that the ventricle ipsilateral to the infarction is almost similar to the ventricle on the opposite side. Then in the era before MRI, we used to have this terminology, which is known as the hyperacute infarction, or what's known as infarction in evolution. You may have a patient who is presenting by a stroke. Then you perform an immediate CT scan, and you can see that the scan is normal. And after some time, the follow-up scan will identify the infarcted area, because you know that the ischemic brain tissue needs some time to appear on the CT scan. But nowadays in the stroke centers, the patients with hyperacute infarction are managed immediately in order to dissolve the thrombus and to prevent this irreversible damage of the brain tissue adjacent, as you can see here. Then also in this domain, in the domain of hyperacute infarction, you may use what's known as the stroke window. And the stroke window is just to adjust the window to see more clear the brain parenchyma in the suspected area of an infarction. Can anyone suspect the infarction site here in these two images? This the same images, but this is the normal or the usual window, and this is what we call the stroke window. I hope you can appreciate that there is some abnormal density in this area around the sylvian fissure, and this has been confirmed clearly by the diffusion weighted images, and you see this infarction around the insula. And by MR angiography, and you can see the attenuation of the middle cerebral artery. Then this is an infarction, with follow-up after 4 days. This is the infarction, and after 4 days, and you can see the marked enlargement of the infarcted area. And whenever you see the infarction on imaging, and you know that this is irreversible brain damage, and that there is no way to revitalize this dead brain tissue. And this is the case before the era of MRI, and you have to look at the infarction every now and then. This is an acute infarction with the mass effect, and after some time you got a chronic infarction with a vasodilatation of the ipsilateral ventricle. Sometimes you may have an infarction with internal hemorrhage, and this is an infarcted area with foci of recent blood. And the causes of a hemorrhagic infarction are either one of two. Number one, venous occlusion, and the occluded vein will prevent the flow of blood across the capillaries. Then the capillary blood pressure will be elevated, and capillaries will rupture and producing this appearance. The second cause is arterial embolism. And after an embolus has occluded an artery, then the recanalizing effect of the body will initiate a very small tract through the embolus, through which the blood will be pushed against the one of the capillaries which will rupture, producing hemorrhage inside the infarction. Then it's not difficult to diagnose the hemorrhagic infarction itself, and you see an infarction, large area of hypodensity containing foci or areas of recent blood density. This is hemorrhagic infarction. But what is more important is to look behind this appearance for the most likely cause. Either you look carefully for the venous sinuses, for venous sinus thrombosis, or you judge the clinical picture of the patient for cardiac troubles, which may be the source of emboli. An hemorrhagic infarction due to venous thrombosis can be seen by CT and by MRI. Here you can see the hyperdensity within the sagittal sinus and the hemorrhagic infarction in the right high parietal region with hypodensity and hyperdensity. MRI is of course a good way to detect venous thrombosis, especially in the T1 weighted images, both in the axial and the sagittal image. This is the thrombosis of the superior sagittal sinus as well as some of the draining veins inside the sinus. If you look here, and you can see the region of the superior sagittal sinus is bright in the T1 and also bright in the T2, meaning that there is a superior sagittal sinus thrombosis. Then look carefully here, and you can see an area which is low signal in the T1, high signal in the T2, containing hemorrhagic foci. And if you see this hemorrhage, you can identify that it is of the early subacute type, because the blood is bright in the T1 weighted images and is dark in the T2 weighted images, meaning that there is intracellular methemoglobin. In order to identify clearly the sinus thrombosis, you should have the sagittal T1 weighted images, and I have explained the anatomy of these sinuses in the first lecture. Then before the era of MRI, we refer to this sign which is known as the delta sign by CT after contrast injection, and you'll see the thrombus as a filling defect inside the enhancing superior sagittal sinus, giving the delta appearance. But with the era of MRI, you don't need to inject contrast media. Just you look at the anatomic site of the sinus in the T1 and in the T2 weighted images, it will appear bright like this. And you also don't forget to look for the superficial veins on the surface of the brain. They may contain also thrombi. And this is a good example of hemorrhagic infarction by MRI. And this is the infarcted area in the T1 weighted image. In the T2 weighted image, you see the infarcted area is bright. But inside this brightness, you can see a dark area. If you go back to the T1 weighted image, you can hardly see this area here, meaning that it is of intermediate signal in the T1 and the black signal in the T2, indicative of a hemorrhage inside the infarction. And hemorrhage can be easily detected by CT in the acute phase and by MRI in the subacute phase, particularly where you can see high signal blood within the infarcted area in the right temporal region or temporoparietal area. And this is the T2 weighted image, and this is the FLAIR image. By CT, the hemorrhage will disappear by time, and you can see this is an infarction. You cannot know whether it is hemorrhagic or not, but if you look to the MR images, you see the brightness in the T1, the dark signal in the T2, indicative of early subacute blood, which is intracellular methemoglobin. This is an infarction in the vascular territory of the posterior cerebral artery on the right side. Then a lacunar infarction, by definition, is an infarction which is smaller than 1 centimeter in diameter. And this is a lacunar infarction in the anterior part of the right thalamus. Many lacunar infarctions in the basal ganglia around the ventricles will produce this disease, which is known as the subcortical arteriosclerotic encephalopathy. And here you can see too many lacunar infarctions. The infarctions will appear black in the T1 and bright in the T2, and also bright in the FLAIR images. These are two different examples of lacunar infarctions around the ventricles, producing high signal foci in the T2 and in the FLAIR images. And this is another example of lacunar infarctions. The infarctions are usually hardly seen in the T1 weighted image, but can be identified in the T2 weighted image and also in the FLAIR image as bright signal in the periventricular area on both sides. Then this issue will bring us to one of the famous differential diagnoses of lacunar infarctions, is the plaques of MS. And we will discuss MS in another lecture in full details, but I would like just to show some of the facts. You know that MS occurs in young patients, usually around the age of 30 years old, and the MS plaques are very close to the ventricles, especially near to the corpus callosum, and they usually are perpendicular to the ventricular wall, and they show high signal in the FLAIR images and in the T2 weighted images. And after contrast, the plaques may enhance if they are represent an active disease. But I will, as I have said, will discuss this MS in full details in another site of these presentations. And just I'll show you some examples in order to appreciate the difference. The major differences lie in the age of the patient, which is around 30 years old, and the lacunar infarctions are usually in old patients with known history or good history of hypertension plus or minus diabetes. The MS plaques are intimately related to the ventricular wall. The infarctions are usually located away from the ventricular wall, and the affection of the region adjacent to the corpus callosum is one of the supportive evidences for MS. And in the enhancement, you know that lacunar infarctions do not enhance, but the MS plaques usually enhance if they are active plaques. And the plaques may occur in the brain parenchyma and also in the spinal cord. And I will explain this in full details in later on, inshallah. Then subcortical arteriosclerotic encephalopathy, meaning that there are too many lacunar infarctions in the white matter, or the ischemic white matter disease. And this disease is usually seen in hypertensive patients, plus or minus the presence of diabetes as well. This is the normal appearance of the brain parenchyma, and you can see the white matter with its normal density. But whenever the white matter is ischemic, it will be too dark compared to the normal white matter. And here you see an old person with ischemic white matter changes presented in the form of exaggerated white matter hypodensity in this CT scan. And here is a subcortical arteriosclerotic encephalopathy, where the white matter showed exaggerated hypodensity in the frontal and occipital area. And through these hypodensities, one of the acute infarctions can occur, and by CT it's very difficult to elicit this acute infarction within the hypodensity of the white matter. Then one of the most sensitive techniques is the diffusion weighted images, and you know that the recent infarction will show restricted diffusion, meaning that it will appear bright whenever the CSF is black. Then the subcortical arteriosclerotic encephalopathy can be diagnosed by CT based on the presence of hypodensities, extensive hypodensities in the white matter, and in the MRI, hyperdensities in the white matter, both in the T2 and in the FLAIR weighted images. And you may use the diffusion weighted images in order to pick up the acute infarctions and discriminate them from the old ones. And you see in this example, in the CT, you cannot appreciate the presence of an acute infarction, and also in the FLAIR weighted MR images, but in the diffusion weighted images, and you can see this area of acute infarction, which will explain the patient symptoms. Then we came to a very important issue, which is known as the posterior reversible encephalopathy syndrome. And you know that from its name, it's posterior, occurring in the posterior circulation mainly, usually in the cerebellar hemispheres and the occipital and temporal lobes, but it may extend to reach the frontal, the parietal, and even the frontal lobes. And you know that this encephalopathy is reversible, and by follow-up you may see regression of the lesions. And there are too many explanations for this encephalopathy syndrome. The most likely one is the sudden increase in the blood pressure will result in vasospasm of the intracranial circulation to prevent intracranial hemorrhage, and because of the posterior circulation is relatively weak compared to the anterior circulation, then you may expect the changes to occur in the posterior circulation more common than in the anterior circulation. Then the changes will appear in the CT as hypodense cortical and subcortical lesions. In MRI, they will show low signal in the T1, high signal in the T2 and the FLAIR images. And if you have diffusion weighted images, it will show normal finding. There is no restricted diffusion. The hypodense foci usually affect the posterior circulation, and it may also reach, as I have said, the frontal and the temporal lobes. Basal ganglia and brainstem lesions are less frequent in this particular disease. And this is an example. The lesions are usually almost symmetrical and bilateral and symmetrical hypodensities in the posterior circulation, in the occipital lobes, in the posterior parietal lobes, is suggestive of this syndrome, especially when the clinical picture is supportive. Like this patient who presented to the emergency room with headache, blurring of vision, and the blood pressure of 155/110, and the physical examination is within normal limits. Then you see almost bilateral and symmetrical lesions in the cerebellum, in the occipital lobes, and in the posterior parietal lobes. By MRI, the lesions will appear bright in the T2 and in the FLAIR weighted images, while in the CT scan they will appear hypodense. The main presentation of this encephalopathy is seizures, and this is a well-known presentation for the posterior reversible encephalopathy syndrome. Many causes will result in this syndrome, and mostly they are responsible for the sudden increase of the blood pressure, like acute glomerulonephritis, drug toxicity, preeclampsia and eclampsia, thrombocytopenic purpura, and the hemolytic uremic syndromes. And as I have said, this is just a vasogenic edema resulting from severe vascular spasm to counteract against the acute raise in the blood pressure to prevent intracranial hemorrhage. Then infarctions can also be multiple, and they may also seen in the same stage or in different stages. This is an example of two infarctions, one on the right side in the acute phase compressing the ventricle, and one on the left side in the chronic phase causing dilatation of the ipsilateral ventricle. Long-standing infarction may calcify, and this is an example of a chronic infarction showing hyperdensities within the infarction, and these are dystrophic calcification within the infarcted area. Then if you inject the patient who is suspected to have an infarction with contrast media, the infarction leads to disturbance of the blood-brain barrier, and there will be an enhancement which is known as luxury perfusion or gyral pattern of enhancement. Look at this example. This is a T1 weighted image, and this is T2, and this is T1 post contrast. In the T1 weighted image, you see an infarcted area of low signal, and in the T2 it's high signal apart from this area of dark signal, which will represent hemorrhage. The dark signal in the T2 and the intermediate signal in the T1 represents acute blood, and this is the hemorrhagic infarction. after injection of contrast, and you see this extensive enhancement, which is known as gyral pattern of enhancement, secondary to disturbance of the blood-brain barrier. And this is an infarction by MRI T2 weighted image in the acute phase compressing the ventricle, and you may use all the capabilities of MRI, including the T1, the T2, the FLAIR, and the fusion weighted images, and the MR angiography. Like in this case, and you see the MR angiogram shows marked attenuation of the middle cerebral artery and its branches corresponding to the site of the infarcted area. And finally, I thank you very much.